This is Sarah Ray, Assistant Professor of Pharmacy Practice at Concordia University, Wisconsin, and I'm back with you this week for our endocrine module. There'll be 4 lectures that we'll be going through to help cover the material with endocrine disorders, and you can look back at my bio or my brief introduction when I introduced the asthma lecture to learn a little bit more about me. But we're going to start off with thyroid disorders first off today. And as with all of our lectures, we're going to focus in on the pharmacology, how to dose these, things to look out for adverse effects and monitoring, and then any other important clinical pearls or tools that you need to know. So there's 2 very good guidelines that you can look through. I had the links on Blackboard for you, as well as the overall objectives for the whole module out on Blackboard for the hyperthyroidism and hypothyroidism in preparation, besides looking at the textbook. So if we think about hypothyroidism first, we look at the TSH and the thyrotropin stimulating hormone, or TSH. Normal levels depends on the lab, but typically between 0.3 to 5 milliunit or microunits per ml. The lower levels can sometimes occur in pregnancy, so it depends on the trimester what's considered normal and what's considered abnormal. And also, if somebody is acutely hospitalized, there can be elevations or even suppressions, and it's hard to get an accurate look at a patient's thyroid status. Typically, we do treat if the TSH in a patient is elevated above 10. So when we first are approached with a patient who has the high TSH, we want to consider stopping any medications or supplements that they might be taking that is contributing to the anti-thyroid effect. So amiodarone, carbamazepine, glucocorticoids are probably the most common, but some of these others that are listed, lithium, phenytoin, things to think about. Also, kelp supplements come into play, so always asking your patients about their over-the-counter medications, herbal medications, and that sort of thing is important. Otherwise, when we have a patient who has a high TSH and is hypothyroid, we want to treat them with synthetic levothyroxine or T4. It is converted to T3 in the body, which is what's used by the body. We typically avoid the animal-derived desiccated thyroid, which is known by the brand name Armour thyroid. That was what was first available for patients, and so you may still encounter an older patient especially that is taking the Armour thyroid. We've really tried to discourage the use of the Armour thyroid and switch patients to the synthetic. There's been variable concentrations reported. There's been a lot of shortages with the Armour thyroid, and I'm not even sure that all the strengths are even available anymore from the manufacturer. There is also actual T3 that can be prescribed, but usually for most patients, that's not needed. The liothyronine or T3 is not necessary. Our bodies are pretty good at converting T4 to T3. It would only be if somebody was having issues with after you have been prescribing the synthetic levothyroxine, that if you did specific levels and found that their T3 levels were still real low. In patients who are older, over than 50, or if they have cardiac disease especially, we want to start at a lower dose. That's 12.5 to 25 micrograms of levothyroxine every day. Otherwise, a patient who is young, healthy, we usually start at maybe between that 25 and 50 micrograms every day. Keep in mind that a child or a pregnant woman may require a higher dose. If we're using levothyroxine, the best absorption is on a truly empty stomach, which would be 60 minutes before a meal or 4 hours after a meal. that can be difficult for some patients. But typically, you as the prescriber and we in the pharmacy would let patients know that they should take it every day in the morning, about an hour before breakfast. If they can't reliably do that and they're missing the dose or they're having trouble, then if they do take it closer to a meal, that's okay. They're not going to get as much of it absorbed, but if that's what they're consistently doing, then you can adjust their dose accordingly to get their TSH within normal limits, and everything should be okay. A lot of medicines and things can interfere with the absorption of levothyroxine, so it really is important to have patients take it for sure without food, but even without their other medications. These include the bile acid sequestrants and sucralfate, the cation exchange resins, the K-oxalate, bisphosphonates for osteoporosis, proton pump inhibitors, a lot of the minerals, ferrous sulfate, the iron, calcium, phosphate binders, orlistat, which is the cholesterol fat blocking agent for obesity, even the antibiotic ciprofloxacin and some H2 receptor blockers. So important that they take it on their own without any other medicines. There are other things that can affect levothyroxine being absorbed. That includes biliary cirrhosis, celiac disease, if they're taking it with food, grapefruit juice. It's been found that espresso coffee can have an impact, a high fiber diet, and especially in infants that are not getting breast milk but are using like soy or soybean formula, if they're allergic to dairy, can be an issue. The adverse drug reactions that we typically see with levothyroxine, if you can think about it, if the dose is too high, or if you start at too high of a dose, are going to be increased heart rate, nervousness, chest pain, hypertension, insomnia, heat intolerance, all of those things that go along with hyperthyroidism that we'll talk about next. But also unexplained weight loss, atrial fibrillation in older patients, which is why we start at that lower dose. There is also some partial hair loss that can occur in children that is typically temporary. One of the biggest things with levothyroxine is avoiding the medication errors that results, because it is a microgram. 100 micrograms is 0.1 milligram. And so, again, if you're starting somebody at 25 micrograms, that's 0.025 micrograms. And so it might just, or milligrams, sorry. So 25 micrograms is 0.025 milligrams. And those zeros and the points can all get misconstrued in a medication order. Maybe not so much when you're dealing with an electronic health record at this point, but it may be best to just always work in micrograms. You're going to avoid the zeros and the points and things like that. The doses are also color-coded so that a patient can help you as well, like with knowing what dose they're supposed to be taking. We've just seen errors come out when somebody is supposed to be on 100 micrograms and they're getting a 1 milligram. Just different errors that can happen, whether it's you as a prescriber or the pharmacist. For monitoring, we're going to first draw a TSH and the free T4 levels in about 4 to 8 weeks after starting therapy, and we're going to look for the hypothyroid symptoms to lessen. So I just listed out all of the things that most of our patients with hypothyroidism are going to present with. Decreased heart rate, anemia, decreased appetite. If you read through those, it's all a slowing down of the metabolic system. So we want to look for resolution of those symptoms and things to get better. Maybe not entirely resolved, but some improvement in the hair, in the skin, in their libido, any muscle or joint aches or confusion to get better. For continued monitoring then, after that first 4 to 8 weeks, if they are feeling good and the labs look like they're within normal limits, then we continue the same dose of their levothyroxine. We check in about 6 weeks, and then every 6 to 12 months they can be fairly stable. If they're feeling better, but the TSH is still above goal, continue the same dose, but recheck in 4 to 8 weeks because they may come back into goal range at that period of time. If they're not feeling better and the TSH is still elevated, well, then we need to increase the dose. So typically, it's increased by about 25 to 50 micrograms per day. I've seen physicians and providers go even more conservatively. So if somebody was at 25 micrograms to start with, they might go up to 37 instead of 50. So that's just really based on the patient factors. How old are they? What other concomitant diseases do they have? And again, rechecking every 4 to 8 weeks. Ballpark, most patients are going to be maintained on about 100 to 150 micrograms per day. So something to kind of consider as you're increasing the dose. All right, so if we move on to hyperthyroidism, most cases of hyperthyroidism are from Graves' disease. And so that's an autoimmune disorder where you have a very hyper-functioning thyroid gland, and then there's more and more iodine that's being taken up. And so then the thyroid gland forms a goiter. Now, you can have a goiter with hypothyroidism as well, but typically you're going to have it with Graves, with hyperthyroidism. This, you're going to have a very low TSH, almost non-detectable, so less than 0.01 oftentimes. And if you also then draw your T4 and T3, you're going to have very elevated levels of that since you're having a hyperfunctioning thyroid gland. In these cases, radioactive iodine or thyroid surgery is probably going to be what's done. And you may not be directly involved with that, but it's good to know that in the course of therapy, if a patient's preparing for radioactive iodine or thyroid surgery, that's when the thionamides are used. That's methimazole and propylthiouracil. Previously, it was always abbreviated as PTU, but we don't do that anymore because there have been medication errors, so we'll say it out the whole way, propylthiouracil. They both inhibit the synthesis of thyroid hormones. The dosing, typically it's initiated at a low dose and then increased, as with most medications, start low and go slow. Methimazole is 10 to 15 milligrams once a day. That's an advantage to that medication. Propylthiouracil is 150 milligrams daily, and usually it's divided into 3 doses, so that's a little less convenient for the patient. Most of the time, you're going to see any pediatric dosing done by an endocrinologist. There are some adverse drug reactions with these medications. It's very important that you have a patient's white blood cell count before initiating therapy so that you can be on the lookout for agranulocytosis. Aplastic anemia is also a concern. Hepatitis, abnormal hair loss, nausea, headache, arthralgias, those things are less common. In pregnancy, we prefer propylthiouracil, even though they both cross the placenta. Methimazole is preferred in children. There are some drug interactions. Typically, these are not medications that are used a lot. Phenothiazines for psychiatric disorders. There can be issues with agranulocytosis. If patients are on other bone marrow suppressing drugs, you'll get additive bone marrow suppression. So it's really more about the disease, the side effect of the agranulocytosis and aplastic anemia. Propylthiouracil also has some interactions with lithium and potassium iodide, and it can affect warfarin. Methimazole also has interactions with amiodarone and potassium iodide. For monitoring, we typically initiate the dose, as I had stated, and then check the TSH and the free T4 every 3 to 4 weeks, so it's a little more closer monitoring than with hypothyroidism. We're looking to get that TSH in the normal range because it is dangerous to have that patient having the hyperthyroid symptoms. If we look at what the symptoms are, there's heat intolerance and weight loss and nervousness, which aren't that concerning. What we do worry about, they're concerning for the patient, but what we are concerned about is the increased heart rate, chest pain, and ophthalmopathy that can develop in patients that have hyperthyroidism. So we do want to keep a close eye on that and make sure that the patient's symptoms are resolving and that their TSH is increasing. This is similar monitoring as far as compared to the hypothyroidism. If they're clinically stable and euthyroid when you check it at 3 to 4 weeks, you can continue the same therapy. We check at 6 to 12 months, although you'll probably do it sooner than 6 months, or they might not even be on the medication that long, because if you're preparing them for radioactive iodine, they may go off to the specialist at that point. If they're not clinically stable or resolving their symptoms, or if the TSH is still very low, you'll increase the dose. You'll increase the dose of methimazole. You start at 10 to 15 milligrams. You may increase it to 20 and then 40 up to 60. Propylthiouracil, you start at the 150 milligrams. You may be increasing it up to 300, 600, even up to 900 milligrams per day, but it always needs to be in 3 doses. Usually then, after you increase the dose, you're going to see some response in that 4 to 8 week period. Again, like I said, if someone's going off to have radioactive iodine or surgery, they may only be on it for several months to help lower the T4 that's in the body. But typically, otherwise, you continue it for 12 to 18 months. Beta blockers can be used as an adjunct therapy. Where you're going to see that coming in handy is in those patients that are having those sympathetic cardiac symptoms, the rapid heart rate, those types of things. Propranolol also helps, besides decreasing the heart rate, helps inhibit the peripheral conversion of T4 to T3, so that's beneficial. Propranolol is 40 to 80 milligrams by mouth twice daily. On the other hand, you could use atenolol once daily, 25 to 50 milligrams. Typically, those are tapered off. You don't want to just stop them abruptly because you can get rebound rapid heart rate and high blood pressure. So typically, they're tapered down as the patient's symptoms improve, and then they won't need them. So hopefully this was a good review for you from the textbook of how we treat both hypothyroidism and hyperthyroidism. Please don't hesitate to get in contact with me as you have questions and as you prepare for the exam and the quiz.